As it is rightly said, the eye sees what the mind knows. Let us now see where the surfer's mind will take us adrift. To ride the next wave, let me call upon Dr. Ramesh Iyer and Dr. Naresh Biyani sir. Dr. Ramesh Iyer sir and Dr. Naresh Biyani sir. Dr. Ramesh Iyer sir has been our past president of TAP in 2014, the organizing chairman of NEUROSURGEY in 2016, and of course the organizing chairman of our present ongoing TAPICON 2021. He is a senior consultant pediatrician and neonatologist attached at Jupiter, Metropole and the Kids Clinic at Thane. Dr. Naresh Biyani sir is a senior pediatric neurosurgeon currently attached to Wadia Children's Hospital Parel, Bethany Hospital Thane and Jupiter Hospital Thane. He has many publications and papers to his name. I now request Dr. Ramesh Iyer sir to please welcome our esteemed speaker.
We all welcome Dr. Uday Andar sir, the speaker for the session. Sir, as it mentions, is the director of clinical services of the upcoming dedicated pediatric hospital in Thane, that is known as the MRR hospital. Sir has been pediatric neurosurgeon for many years. He has been worked at KEM and then gone abroad to Newcastle General Hospital, and also at GOSH, that is a Great Ormond Street Children's Hospital, London. Sir had worked for many years, and most importantly, sir has got 50 publications in journals and 10 chapters sir has written in neurosurgery textbook, and is still the MOHS teacher for neurosurgery. I think Dr. Naresh Biyani would like to add few words about Dr. Uday Andar sir.
Thank you, Scientific Committee of TAPICON, for inviting Dr. Uday Andar sir. I have been knowing sir for past 22 years now. He is instrumental in sending me for fellowship at GOSH. He was trained at GOSH till 93. And when I came back in 2008, sir has been the first person and the only person who told me, Naresh, you do only pediatric neurosurgery. This is almost now 13 years. Pediatric neurosurgery for sir is a passion. He's been doing great. He's a pair of golden hands with very good heart at him. He is instrumental in starting the pediatric neurosurgery fellowship at Wadia since now past 7 years, and every year we are training 2 pediatric neurosurgeons. TAP is going to enjoy this.
Over to sir.
Thank you very much, gentlemen on the dais and all my colleagues and friends, and thank you very much for TAP for having invited us to today's little speech. Well, coming from vaccinology to gastroenterology to neurosurgery is a big jump. But Thane is not new to me, to tell you the truth. I started practice in Thane in 1986 when I was to live in Vrindavan Society and travel to KEM Hospital. Where I was a lecturer. So at that time I used to work at Bhanushalia Hospital and various other big nursing homes at that time. In 1988 I got the opportunity to go abroad to the United Kingdom, and I took it. I had the opportunity to work in one of the best hospitals there. And now that I am back, I'm very happy that I'm back in Thane, because I have always had a soft corner for this place. And I'm very happy that when I'm coming back, I'm bringing this project for the treatment of children, which will not only be a city's permanent jewel in its crown, but a pride of this state and the country. Having entered pediatric neurosurgery in 1990, it was a time when it was just getting recognized as a subspecialty, just getting recognized. I was lucky to have gained experience at the best centers and worked with the best names in the subject, especially with Prof. Fred Epstein and Professor Richard Hayward. They were the first generation pediatric neurosurgeons, so you can call us the second generation of. During this time abroad, I have been lucky to have contributed to original studies, especially in craniofacial anomalies in spinal dysraphism. And when I came back here, this took me further down to congenital scoliosis and associated occult dysraphism. But as decades have passed, so has the philosophy changed, and the management of all these conditions have changed. And approaches to the subject have also changed. But change in medicine and its practice is what keeps us all going, as well as engaged in our specialty that we like to pursue. Pediatric neurosurgery itself has seen further subspecialties like craniofacial, spinal dysraphism, epilepsy, tumors, oncosurgery, vascular, interventional, and surgical specialties, including spasticity. So, in the West, one would see pediatric neurosurgeons who are also doing very exclusive work in their own subspecialty. Here in India, we are as yet not getting into it, but I think many of us are doing what interests us, especially at Wadia, where we have a large unit, and we have the pleasure of working with a huge reference base. So coming to craniofacial surgery, it has evolved over the many years, and it continues to evolve, and just as all other branches of surgery. In the better understanding on the growth of the craniofacial skeleton itself has been the fibroblast growth factor receptors and so on, and the various driving forces that promote and demote the growth of the skull. Though this was recognized for many centuries, it was only after 1990 that it realized that these children have problems with high intracranial pressure. They also have problems with airway obstructions because of their syndromes. And then this is the study we conducted in Great Ormond Street to identify what problems they were and how we can sort it out. Many considered Paul Tessier as one of the fathers of neurosurgery, of craniofacial. And this study, especially which was done at Great Ormond Street, was criticized by many across the Atlantic because there were little children with Camino monitors stuck into their head, which was not a pleasant sight. I'll show you one of the pictures. But finally, it helped to decide the right time for the surgical intervention and gave an insight not only to the timing but also to the type of procedure that can be performed. So what we learned from this is that in a single suture involvement, whether it is just a coronal, just a sagittal, or just a metopic, the ICP is never raised. And what does this mean? It means that the onus of explaining the surgery goes fully on the operating neuroplastic team. Because we know that this is a purely cosmetic operation, the parents need to be explained about it. We need to tell them that, look, this is a major surgery, this is a single suture, there is no raised pressure, we don't need to rush it up. But yes, in today's world, there can be a lot of peer pressure, there can be a lot of familial pressure, and for an abnormal face or a craniofacial anomaly, it may be a problem as the child grows up, but it is a purely cosmetic reason that we are operating. In a double suture involvement, the ICP raised is in about 20%, especially in those which are syndromic. If non-syndromic double sutures, hardly ever the ICP is raised. This is what we observed. But in multi-sutural ones, the ICP is invariably and almost 100% raised, especially in those syndromes where there is associated choanal atresias and there is a short posterior fossa with a blocked transverse sinus or so on. So in bicoronals, hardly 20%. Is it cosmetic? Yes, it is a cosmetic surgery along with an 20% risk of causing raised pressure and problems. In syndromic ones, it is definitely a indication to do some kind of decompressive procedure to relieve the pressure. And many a times, if you look at this kid and you look at the scan, there is extremely telltale signs of raised pressure there, with a copper beaten appearance, with a heaped suture line, which in your clinic, when you just push your hand over the head, you can actually feel the heaped, the heaped suture. These kids require intervention to prevent them from becoming intellectually challenged. This is I'm sure all of you have identified, this is Princess Diana. I'm trying to explain to her why we have put that horrible looking thing into that patient's head. She thought we were torturing that child, and we had to explain that no, this is not, it is for something that is better to do. I got involved in that, I was part of the team that operated on her son, Prince William, for a compound depressed skull fracture, and that's why we were interacting very regularly. The royal family is the patron of Great Ormond Street, and they come there pretty regular. So that is how it looks, the Camino monitor stuck into the frontal head. So what's the best time to operate on these children? Universally, sagittal synostosis is considered to be done very early in life, 3 to 6 months of age. All others are done between 9 to 18 months of age. If we do it too early, there's a danger of recurrence. Pansynostosis, especially the syndromic ones, because they have raised pressure, young age, even 6 months or earlier, then what do we do? Then we open the posterior part of the head without touching the frontal, and the frontal remodeling is done at a later stage. Because if you do frontal remodeling before the age of 6 months, the rate of recurrence is extremely high. This surgery, as I said, has evolved. It has come to endoscopic. Endoscopically, we can open the sutures with small incisions, less blood loss, but we have to do these pretty early. We have sometimes use a helmet to keep it under control. But the problems with this is again high recurrence rates. And when I say high, they go almost to 40-50%. What is the next therapeutic level? Maybe genetic remodeling. Because we know that the fibroblast growth factor receptor genes are responsible for causing early suture closure. If we find some way of stopping that, maybe we have hit the target. My next topic of interest was split cord malformations of the lumbar region. This paper too made a very landmark dictum in the prophylactic repair of the diastema type 1. It was done when there was a lot of debate going on in the fraternity about whether they should be operated, they should not be operated, whether the tight phylum should be released, not released, whether it should be done after the neuro deficits come on, or whether it is prophylactic. So in this study, we presented a model for the neurosurgical management of all types. But the maximum contribution came because of the invention of the MRI scan. It is the MRI scan which started showing us exactly what was happening inside the spinal cord. With a myelogram, all this was not possible. So the MRI and the 3D CT was actually what we learned a lot of things about. There is something called neuro-orthopedic syndrome that happens with these children. Why does it happen? And what is neuro-orthopedic syndrome? It is a thin leg with a small foot, often associated with a pes cavus and talipes on the same side. No serious functionality problems. The motor power can remain 4+ to 5. Maybe slight sensory trouble, but no motor. And sphincter problems are very unusual in split cord malformations. Why does this neuro-orthopedic syndrome occur at all? It occurs at all if you look at the scan on the right. The cord does not get split into two symmetrical halves. Sometimes one side is smaller, the other side is bigger. The side on which the cord is smaller will have the smaller leg and the smaller foot. The side on which the cord is normal will have a normal leg and a normal foot. But the motor power hardly gets affected. And when do we see this? Sometimes it is not seen at birth. It emerges. This neuroorthopedic syndrome is something that emerges around the age of 6 months. It's not actual deterioration. It is the emergence of a deficit which has been put in by the manufacturer, unfortunately. The asymmetry of the limb seldom changes. We have to remember that in spite of removing the tight phylum, in spite of removing the bony spur, the difference in the spinal cord does not change, and therefore the difference in the leg will not change. But there can be acute deterioration. Acute deterioration, what is acute deterioration? You know, in all normal children, there are growth spurts, and there are for the first age growth spurt is at about 2 years, 2 to 3 years, and then at puberty. There are 2 growth spurts that occur. And at these growth spurt time, and then the spinal cord suddenly, when the height of the vertebral column increases and the spinal cord straightens out, there can be early muscle involvement or even sphincter involvement. So this operation of untethering and removing the bony spur is usually done before 2 years of age, when they present with a neuroorthopedic syndrome or sometimes just pain. So the current evidence justifies excision of the bony spur and the untethering of the cord before the first growth spurt, that is below the age of 2 years. But there are many who miss it. There are many who miss the second stage, and many a times we have seen adults presenting with pain going down the leg, radiating pains, some of them getting urinary sphincter problems. And whenever we untether and we remove the bony spur, most of these, even in our study, we have shown that 95% of these recover completely. So, in many ways, this operation that we do before the age of 2 years is a prophylactic procedure, and this needs to be very well explained to these anxious parents in details. What is the purpose of surgery? Is to release the neural tissue from all points of fixation, because it can get fixed and the lateral posterior, it can get fixed at the bottom, which is the most common, and keep it in that unfixed position for in the future as well, to avoid retethering. What happens to asymptomatic patients from neurological or neuroorthopedic syndrome point of view? In the type 2 diastematomyelia. What are type 2 diastematomyelias are? Where there is no bony spur, but yet there is a phylum which is tight and tethered. They may still have back pain, and that's why they have done an MRI. What do we do? You have an option. Sometimes we observe, sometimes if the anxiety levels are too high, surgery can be done without much problems. If you in a clinic see these hairy patches, be sure that there is a 90% chance this child has a diastematomyelia. And if there is a scoliosis like this, 100%. So skin markers like hairy patches, dimples, and other things are possible. These children not have sphincter problems, unexplained back pain, scoliosis or kyphoscoliosis. And having said that, we come to kyphoscoliosis and scoliosis, which is my third area of interest, which we have presented in a chapter as well as in the progress of orthopedics. The need for evaluation was critical because many of the spine surgeons who were operating on these suddenly found that these little children were getting iatrogenic neural damage. You straighten the spine and the child goes paraplegic. You straighten the spine and the child gets some sphincter problems. Why? In the earlier stages, none of them were investigated. Now we do. We have to scan every scoliotic child that you see, and I'll tell you why. Because in this study of this large number over 20 years between Dr. Johari and myself, we have realized that 1 in 2 children of these congenital scoliosis have an intraspinal dysraphic, some kind of dysraphism. And this needs to be addressed much before the scoliosis correction is done. And unfortunately, these dystomatomyelias and other dystrophic areas are high cervical or thoracic regions, which are more dangerous than in the lumbar. And the most common intraspinal anomalies are the tethering as well as syringomyelia. We have found in this study as well that syringomyelia is the most significant reason for neurological deficits in congenital scoliosis. The orthopedic surgeon who is correcting the spine, if he sees syringomyelia, then he better beware. There are various types of scoliosis that occur because of bony abnormalities, and this is the distribution of them percentage-wise. But on an average, it's about 56% have problems of intraspinal dystrophics. This suggests that we need to scan them very early. You also need to scan them early if you see in your clinic a rapidly progressive curve, you find some neurological deficit, and both of these call for urgent MRI or CT of the spine and consideration for an intervention. When we started this, we were operating this case right at the beginning. Yeah, okay. We were operating these cases in one stage. I would detether and the orthopedic surgeon would fuse. But we found that because of the length of time that is taken, there is high morbidity of the patients, and therefore we changed this completely. And now almost all centers who are doing scoliotic surgeries are doing these at separate times with a time difference of about 3 months. And both these operations should be done with intraoperative monitoring. So when one takes and undertakes these kind of various craniofacials and scoliotic surgeries and epilepsy surgery and so many other things, not only in neurosurgery but in other branches of transplantation of liver and kidneys, and so many things have come in pediatrics, you require a dedicated children-oriented place. It is very difficult otherwise to carry on this work. And therefore we thought that we will present this city with this beautiful hospital which is linked with Sick Kids Toronto, and we will be handled, we'll be directly in, we have signed a memorandum of understanding with them for medical, paramedical and every little help that we need. It's a very good collaboration, and I think it will do a lot of service. This is a charitable trust which is setting up this hospital here. And if you see this, all that any modern hospital has is here. The USP over here is the MEG imaging for epilepsy, which is not available anywhere in this country. We have all systems as well as free wards. We have indigent and double sharing and single rooms and so on. And the specialties, lead specialty being neurosciences, gastro, pulmonology, rheumatology, and other developmental pediatrics and so on. We have everything that a pediatric specialty will require, including allied health. And this is how our CT and MRI will look. This is how our DSA and other things, the gastro radiology will look. Thank you very much for listening to me patiently. Thank you very much.
Thank you so much, sir. Special mention for you to be prompt on time. I now request Dr. Naresh Biyani, sir, to please, sir, any questions?
What sir were trying to tell was that is a prophylactic surgery that has changed, revolutionized. Nowhere in other part of surgery field, surgical fields, that a prophylactic surgery is done. Craniostenosis and spinal dystrophism, there is a big role of prophylactic surgery, and this is what sir was trying to point out. Any questions, please?
In patients who have extramedullary erythropoiesis like thalassemias, once we have taken care of their transfusion program in an optimum way, if they already have those frontal bossing, and they grow up with that, and that's because they landed up late with us. And actually we are not transplanting those who are into such severe conditions, but suppose we offer them treatment in the form of transplant, or we shift them to an optimum transfusion program later, can this be corrected? Because now we have a lot of growing up thals who have grown up, to the age of 20, 25 and even beyond. So they are worried about their looks. So can something be done for them?
We normally don't indulge in secondary causes of craniofacial anomalies. And I don't think it causes any decompensation of the brain in any way. So it's very unlikely that we'll like to interfere in this. Any comments, Naresh?
Dr. Ratna, I have operated 2 of them actually. Thalassemia with abnormal skull shape, and one had a craniosynostosis. The only challenge that we have got is that the disease has to be optimally treated, number 1. And number 2 is that they can bleed to death. It's a it's a very vascular surgery, and people who are not trained in looking and seeing that, we lose the child on table actually. So that's the only care that we have to make sure it has been done. And one of the child that I have operated has done very well actually because of the raised ICT. And they have, if you see a skull X-ray, they have this spike, spikes, and that everything has disappeared. What you are trying to tell is the cosmetic surgery that is available, and yes, that we call as a reduction cranioplasty, we do it. But the only thing is that we should be careful about the blood loss and the morbidity associated with the surgery. Pardon, ma'am? Correct.
You will have more patients actually coming, they are interested because they are bothered about their looks, and we are looking at giving them a near normal life. So this aspect really bothers them.
No, as the field is advancing, even the hematology, the neurosurgery, like when I started, I would see at least 3 children of craniosynostosis in a year, Now we are operating at least 35 cases in a year. So the volume is just going to increase.
Thank you.
I would request Dr. Ramesh Iyer sir to please felicitate Dr. Uday Andar sir. On behalf of TAP team, I would like to request Dr. Grivita to felicitate Dr. Ramesh Iyer sir and Dr. Naresh Biyani sir.